So you can see there's a lot of economic stimulus coming out of the EHR program. So let's talk about eligibility very basically. Meaningful use, with a very small exception, did not change the eligibility criteria. There's only one, and that is a slight tweak to the definition of hospital-based eligible professional. We do allow physicians now who totally maintain and acquire their own hardware and software interfaces to achieve meaningful use and receive physician meaningful use, even though they are hospital-based. So I can think that certain emergency physician groups, certain radiologists, et cetera, maybe certain primary care doctors as well, could have that option, even though they're hospital-based, if they didn't want to totally come under the umbrella of having the hospital CIO or CMIO determining what system they buy or buying the system for them, but they have to maintain that on their own. Then they can get the physician incentive. And once again, this just shows the glide path. We started in 2011, so hospitals that started were early adopters in stage one. The green is stage one. Will be transitioning beginning in October to stage two, as will hospitals who started stage one in 2012 will be transitioning in stage two to meaningful use. I said hospitals. This is for physicians, but the glide path is the same. And then once you've been on stage one for 2 years, if you adopt in 2013, then you'd go on to stage two in 2015. If you wait till 2014, you'd be eligible to go on to stage two and would be required to in 2016. And of course, stage three is out there, and the regulations will be determined. For Medicaid, we don't have that declining. You notice the later you wait, the smaller bonus you get. It's very front-end loaded, both for physicians and hospitals. So late adopters do not get the full benefit of the incentive that early adopters have. Medicaid, however, is more linear. You get the first upfront payment of $21,000 your first year when you adopt, implement, or upgrade, but then subsequent years stay a flat level payment of $8,500 for your success and meaningful use. And providers have up until 2016 to participate in the Medicaid Meaningful Use Program. And, you know, especially for states that are choosing to expand their Medicaid program, of course, Georgia's not yet one of them. We hope at some point Georgia may choose to, but that's not a decision for the federal government to make. But you can see that some physicians, this is a little more forgiving program. It's a little richer, actually. Physicians can get $63,000 as opposed to the $44,000 on the Medicare side. There are incentives to go for the Medicaid Meaningful Use Program as well. That, of course, is much more popular with pediatricians and family practitioners. Primary care docs are those who are primarily going after Medicaid. Hospital glide path, I mentioned, is the same, and I didn't put the figures in because that's a function of total Medicare bed volume, but you know, it basically starts at around $2 million a year, plus or minus a utilization factor, so incentives can be extremely large for hospitals as well. So meaningful use, the changes, here's a little bit of a schematic from stage one to stage two. As you all know, we have objectives and we have measures. And in stage one, professionals had 15 core objectives. We've bumped that up to 17 core objectives. And they had 5 of 10 menu objectives, and we've reduced that to 3 of 6 menu objectives they have to achieve because we've made some of the stage one menu objectives core objectives now. You see that the total number of objectives, however, stays the same. And similarly for hospitals, we've gone from 14 core to 16 core, and once again, a little bit less on the menu options as more menu objectives became core and mandatory, for a total of 19. Certification standards. You all know that to participate in meaningful use, you need to have a certified system as certified by the Office of the National Coordinator and their certification bodies. You know that there's a list, and I tell everybody, and for those of you who are vendors, I tell physicians and hospitals, don't get married to a system without going to the chapel. Before you get married, go to the chapel. And the chapel, of course, is the certified HIT provider listing, whatever. That's the official list of all the systems that are out there, all the software, whether it's 1.0, 3.2, whatever. Make sure that your system is certified and on that list. Now, in 2014, to accommodate more of the robust changes in meaningful use, we will have a second round of certification standards. And the good news is to allow providers time to adopt those 2014 certification standards, the participants will have a 3-month reporting period in 2014. So that previously to your second year of meaningful use, you had a 1-year reporting period. But to allow you time to transition and test out your newly certified system, for the 2014 year, you get to report your data in 3 months. Then you go back to 1 year in subsequent years. Just to list our stage 2, some of our stage 2 core objectives, and many of them have remained the same, although the numbers required, the percentages required have increased. So you now have to use CPOE, clinical order entry for 60% of your medications, 30% of your labs, and 30% of radiology. You have to ERX for more than 50% of your prescriptions. And we've increased the percentages on the rest of those. And you have to implement 5 clinical support interventions in addition to any drug or drug allergy clinical support interventions you have. You also have to have preventative care reminders for more than 10% of your patients that have 2 or more office visits in the last 2 years. Now, this second page is even more important because physicians have to provide online access to their health information to patients through a portal or otherwise for more than 50% of their patients, and at least 5% of the patients actually have to access the system. In the final rule, we've reduced the percentage of patients that actually have to access the system down to 5%. Physicians felt that the prior proposal was a little too high. Physicians argued that they couldn't necessarily control their patients' behavior. But then you can see that for meaningful use, we are emphasizing 2-way doctor-patient, hospital-patient-provider communication. And once again, summaries of care. And I know some people consider this problematic, but you need to provide a summary of care document for more than 50% of your transitions of cares and referrals. Now, a summary of care document still can be written. It still can be transmitted by patients hand carried, except at least 10% have to be sent electronically between transitions of care. And you also have to demonstrate that you can send one to a recipient with a different EHR vendor, or successfully test that you can send a transition of care through our test module. And that's because obviously there are a lot of integrated hospital systems, Janet was talking about, that can talk to each other within their system, but they can't talk to each other outside of their system. And this is to ensure that your system, even though your general referral patterns may be totally within your healthcare system, if you've got an integrated system, you have to demonstrate that you can talk to another vendor, which we might assume might be owned by another system. If all systems use one vendor, then you've got to be able to talk outside that vendor. So the vendors obviously need to get together and make sure they're all talking to each other, and that, of course, will be a requirement for certification for meaningful use stage 2. The menu objectives, once again, we have 6, and 10% of imaging results are accessible through certified EHR technology. That should be pretty easy. As an ER doc, I was often able to pull up x-rays and CAT scans on my healthcare system EHR. Family history, syndromic surveillance will have a huge impact on public health. Cancer registries, specialized registries, and also you have to be able to enter a unique progress note for more than 30% of your unique patients. So you have to enter progress notes, not just histories and physicals. Hospital core objectives are pretty much similar to what we mentioned before: clinical decision support with the addition of electronic medical administration records, EMR. That hospitals have that physicians don't have. So hospitals that are administering medications to patients need to use the electronic administration record at least more than 10% of their medication orders. Are you familiar with that, when you might scan a barcode of a med to make sure that the med that is ordered gets into the patient that it was ordered for? So wristbands are getting scanned, and et cetera, and that's being integrated. Same thing with patient access to their medical records, same provision as physicians. 5% actually have to access their hospital records, and 50% have to have it available to them. And the same thing with sending summaries of care through different vendors, or at least demonstrating through our test module that they can do that. And the hospital menu objectives, the one important one, ERX hospitals are now going to have to incorporate electronic prescribing. That's new for hospitals in stage 2. Imaging results are the same thing, progress notes, and advanced directives are very important for more than 50% of patients 65 years or older. And no, that's not death panels. Okay, but as an ER doc, if I had a nickel for every patient that came in from a nursing home on death's door in my ER, and the first thing I have to do is have a nurse, would you please call the nursing home and ask them what is their family and their advance directive? You know, you say, they have an advance directive? Well, yeah. I don't want legalese. I want to know, am I going to do cardiac resuscitation on this patient, or am I going to put this patient on a ventilator? And I've got about 5 minutes to make that decision. I don't need to be speaking at 2 in the morning to a nurse's aide at the nursing home who has to call the supervisor and find out and look in the chart whether we have an advance directive. And you also see the labs have to be structured so that lab reports are incorporated directly from the lab into the hospital EHR, not simply scanned in a PDF format. And once again, I mentioned the key to stage 2 is patient engagement, patient engagement, patient engagement, the two-way interface and communication between physicians and patients and hospitals and patients through their electronic records. You know, right now, the old days, patient wanted to see their record or their progress notes. It was like, oh yeah, before EHR, well, you got to get a letter from whoever, and you got to go this, and you have to pay this amount of money for copying, and go down and get it sent from our file room, if we can find the file, well, that obviously is changing. And that's going to get patients engaged better in their care. And once again, this reiterates the electronic exchange requirements that I've talked about. Clinical quality measures. As I said, improving healthcare is not just about cutting costs, it's improving quality. Because the studies show quality care is generally more efficient care and more affordable care. And we realize that there's a plethora of quality measures out there. We are trying to integrate these measures into all of our programs. And down the road, all of these quality measures will be reported electronically. They are remaining the same through 2013. And in 2012 and 13, you had two measures. You could attest or you could do e-reporting. Now, in 2014, we're changing the number of measures. Excuse me, I just want to make sure I didn't slip one. We're changing the number of measures, quality measures. Instead of reporting 6 out of 44 clinical quality measures, physicians have to report 9 out of 64. So they have to report more, but they get more choices. However, they need to be reported from at least 3 separate national quality system domains, and I'll talk about that in a second. Same thing with hospitals. Hospitals prior to 2014 had to report 15 out of 15 quality measures. They'll get more of a choice now. They have to report 16 out of 29 quality measures. Once again, at least 3 separate national quality domains. What are the domains? The quality strategy domains are the following: patient-family engagement, patient safety, care coordination, population, public health, efficient use of healthcare resources. There's going to be efficiency measures they can report, and clinical process and effective measures. And as I mentioned, we understand at CMS that physicians and hospitals are being inundated with quality reporting and measures, and we are working very closely to align our quality reporting system beginning in 2014. So our inpatient quality reporting program, our physician quality reporting system, our children's health quality, and our shared savings and Pioneer ACO quality metrics will become aligned. And just today, I can report, it was announced internally to us at CMS and to the world, that our chief medical officer at our national headquarters, who had been doing double duty as both our director of our Office of Quality Standards and was temporarily filling in to be our director of our CMMI Innovation Center, has just been named to be the permanent director of both our Innovation Center and our Office of Quality Standards. So our national chief medical officer at CMS, our own organizational structure shows that we are trying to further align the tops of our boxes and our silos so that innovation and quality reporting, ACOs, all of that are all now being better aligned for you and within our own organization. I mentioned in 2014 you need to, in your second year of meaningful use reporting, you have to electronically support your data. Your first year, you can still do it by attestation. Medicaid providers will report the way their state directs them to do, which may include electronic reporting. And we also will have recommended core sets of clinical reporting measures if you choose to use a recommended set, but that is optional. But we have recommended reporting sets if you want. And you can see what those detailed ones are at our EHR Incentive Program website. And some of our recommended core quality measures for physicians and other providers are those conditions that contribute most to the mortality and morbidity of most of our Medicare and Medicaid beneficiaries. Obviously, when we talk about why are there so many measures for diabetes, congestive heart failure, COPD, chronic obstructive pulmonary disease, cardiac disease? Well, there's a reason. Those are all the big 5 areas of morbidity that drive most of our costs. That these are the comorbidities that people have that drive almost 80% of Medicare costs are those major diseases. So we want to improve quality in those areas. Payment and adjustment hardships, as I said, the HITECH Act provides that for those providers, hospitals and critical access hospitals and physicians and other providers, they will get a payment adjustment beginning in 2015 if they're not a meaningful user of HIT. And I'll tell you the deadlines they have to meet that requirement. The payment adjustment or reduction will start in 2015. And meaningful use, if you're on the Medicaid side, that doesn't merely mean adopt, implement, and upgrade. You have to be in your 2nd year of meaningful use to avoid that penalty. Into the future, the payment adjustments or payment reductions, if you would, start getting larger every year that you wait. So in 2015, you get a 1% reduction, or 99% of what you otherwise would get on your fee schedule. And then it goes to 2% the next year and 3% the next year. And the Secretary is allowed, through the regulatory process, to increase that to 4% or even 5% if less than 75% of the universe of providers have not achieved meaningful use. In other words, we can increase the sticks a little bit, make the sticks a little bigger if the population is not responding to the carrots. If the population does respond to the carrots, then the maximum penalty would be 3%. There is a little bit of a community impact there, or herd immunity, as we would call it in public health. And the reporting period, for those physicians who've demonstrated, and I say physicians, but EP means eligible provider, nurse practitioners, dentists, et cetera. If you've already demonstrated meaningful use in 2011 or 2012, you have to, your payment adjustment year, you'd have to demonstrate in 2013 that you'd achieve meaningful use. And you have to continue that every year thereafter, 2014, 15, et cetera. 2014, you can do a 3-month reporting period and you have to do that every year in the Medicare program to avoid a penalty in subsequent, every successive years. If you've waited a bit to start meaningful use into 2013, you still have you'll get a payment adjustment if you don't do that in 2013. So the absolute latest that a physician can begin their reporting period is July 1st of 2014. If they haven't reported in 2014 by July 1st, they will get a payment adjustment beginning in 15, excuse me. And that is similar to hospitals as well. And you have to demonstrate meaningful use either under Medicare or Medicaid. Hospital percentages are the same, roughly, and you get a 2%, if you got a 2% reduction, it gets a little complicated because you get an inpatient prospective payment adjustment of 2%. But if you don't achieve meaningful use, you'll get a 25% reduction or 0.5%. I'll let you do the math on that. But you can see that hospitals get reduced as well. And that's a lot more money because the multiplier is a lot larger. And once again, similar similar timetable for hospitals as we just went over for physicians. And hospitals have to demonstrate and attest to meaningful use no later than April 1st. I think that's because there's a difference between the calendar year and the fiscal year for hospitals versus physicians. So that pretty much wraps up the talk, and here's our resource page. You can see if you go to EHR Incentive Programs, cms.gov, it's programs with an S. You can read the regulations, you can get PowerPoints, you can get tip sheets, overview slides of stage 2. It'll cover everything I've covered and more. All your detailed specifications of your quality measures, tables, et cetera. Everything you need there. You can pretty much kill a tree if you print everything out.